Okay, thank you. Yeah, thanks for inviting me. Thank you so much for inviting me to talk about this work. And give this journal a couple. Go ahead and share my screen. Hopefully, you can see that now.
Yes, we can see
Okay,
it.
great. All right, so there are two articles here I'll be discussing. The methods are the same, so just kind of going to batch them as one. But this is a modified Delphi consensus on SCN8A. One paper reviews how we diagnose, phenotype, and treat SCN8A related epilepsy and other neurodevelopmental disorders. And the other goes over comorbidities, um, multidisciplinary care, and that sort of thing. So, first, some background on SCN8A. The variant was first identified as a cause of pediatric epilepsy in 2012 by Michael Hammer and colleagues, actually found in his own daughter posthumously. And now it's been identified as one of the most common causes of genetic epilepsies. Estimated incidence is about 1 in 56,000. That's from the work in the Danish group. The SCN8A gene encodes NAV1.6, the voltage-gated sodium channel found primarily at the axon hillock. And variants that cause disease, at least those that cause epilepsy, most commonly result in a gain of function at this voltage-gated sodium channel. And that's why usually the preferred treatment for these patients is with sodium channel blockers. But that there is some variability there. There is some loss of function that also causes seizures, and the phenotype can be somewhat different. The phenotypes vary, can be mild to severe. I'll talk about that some briefly, just in terms of background. And there's a number of different comorbidities that exist. So the phenotypic spectrum, and this was from work from Katrine Johannesson and Elena Gardella. Uh, it's a spectrum, as with a lot of our genetic epilepsies, ranging really from mild all the way to a severe developmental and epileptic encephalopathy. This understanding has kind of evolved over time, and recognizing that some of these phenotypes may be due to gain of function versus loss of function. It's obviously important to try to have a better handle on that so you know how to best treat these kids. But not only do you have seizures with this, but it's often accompanied by varying degrees of intellectual disability and other comorbidities. The most severe cases, you have severe to profound intellectual disability. These patients are often non-ambulatory. They have cortical vision impairment, really no language, high mortality, including mortality from SUDEP. Not quite as high as with Dravet syndrome, but certainly is a higher risk for SUDEP in this patient population. Again, our thinking on the phenotypic spectrum has evolved some, and this is our article we published in Gene Reviews last year. Um, Again, this came from some work from the SCN80 registry. So we think that there is different phenotypes based on gain of function or loss of function. The loss of function phenotype is more neurodevelopmental disability, either with or without epilepsy. And then again, gain of function can range anywhere from what we called self-limited focal epilepsy in infancy, which can be familial or non-familial, all the way up to severe developmental and epileptic encephalopathy. We say self-limited just because that is the moniker from the ILAE. But many of these patients actually it's not self-limited and go on to have seizures or continue to require anti-seizure medications. The treatment, this is from our clinic data, primarily again with sodium channel blockers, and this is not just from patients with DEE, but also includes those with milder phenotypes. But the best response seems to be, you can see in orange, sorry, in blue there, therapies that are effective are most commonly the sodium channel blockers, followed by benzodiazepines, things like clobazam. We found that levetiracetam was often ineffective for much of our cohort, and that finding's been replicated and can actually make some patients worse both in terms of their seizures and their development. But a number of different medications have been tried. So Our hope was to synthesize all this literature, all this research, and generate guidelines from a global panel. And this work was really spearheaded by um, the Conikers, Jada Hecker and Gabi Conacher, who've done a lot of great work on SCN8A related epilepsy and SCN8A neurodevelopmental disorders, but also all kinds of other developmental and epileptic encephalopathies. So we recognize there's a gap here, and this is the goal to develop some consensus around how we diagnose and treat this. So the modified Delphi process, you might be familiar with the overall process, but we convened a core panel, 13 clinicians, one researcher, and 6 caregivers. We put together literature, drafted questions in 3 groups. We had three groups from that core panel that generated questions on diagnosis and phenotypes, on therapies, and then prognosis and comorbidities. And then developed these survey questions, sent them around to a larger group of experts across the world. And I'll show you some of that. And then refined those questions and completed 3 rounds of questions. And evaluated which ones on which we achieved consensus. So this is our panel here. So the clinicians and researcher experience are on the top, and then caregiver experience on the bottom. Not all questions were asked to the caregivers. If the phenotypic questions were only posed to caregivers of kids who had that particular phenotype, but otherwise all questions were posed to all the clinicians. And you can see here number of years of treating SCN8A and number of patients with SCN8A varied between caregivers and the clinicians, and really represented clinicians and caregivers from across the globe. So we had most from the United States, but also had some representation from Europe, from Canada, and Australia, Brazil, India, and China, and Japan. So we're focusing on diagnosis, phenotypes, treatments, and counseling. Questions were mostly asked via a Likert scale, so whether it went anywhere from fully disagree with the statement to fully agree with the statement, and consensus was defined as either strong, moderate, or modest, or not present. And strong was if at least 80% fully agreed, moderate if 80% fully or partially agreed, and less than 10% disagreed, and then modest if 67 to 79% fully or partially agreed, and less than 10% disagreed. Those that had no comment or didn't know were excluded, and only those with a responder rate more than 50% were used to calculate consensus. Again, for phenotype-specific questions, caregivers only rated their own child's phenotype. Okay, so here were the results and levels of consensus. This won't be all the questions, but those questions that we'll go over those that were generated in that 3rd round and go over the degrees of consensus here. So first, we'll talk about the utility of genetic testing and reason for genetic testing. So you can see here, I won't highlight everything, but clinicians felt strongly that all cases with drug-resistant epilepsy under 3 years of age without a clear structural cause warranted genetic testing. There was moderate agreement that any neurodevelopmental disorder without epilepsy, and then all cases of epilepsy without a clear structural cause, even if it wasn't drug resistant, warranted genetic testing. And this also aligns with the recent recommendations from the National Society of Genetic Counselors on genetic testing in patients with epilepsy of unknown cause. Genetic testing should include either a gene panel or whole exome or whole genome sequencing. There was strong consensus there. And then there was some ideas on parental testing as well, and genetic counseling again felt that a strong recommendation that patients with newly diagnosed SCN8A related disease should see genetics or genetic counselor. Importance of early diagnosis. So there was some consensus that early diagnosis improves outcomes for seizures, for seizure control, for development. Uh, uh, there was not consensus that it improved developmental outcomes. And there was moderate consensus that sodium channel blockers for seizure control does improve long-term seizure outcomes, but not long-term developmental outcomes. There was moderate consensus that determining the function of the variant was important to inform how we treat. I alluded to some of that before, and there was some recognition that it's important to determine the gain of the functional effect if you can. Yeah, if there's questions or comments, we can go over these too. Um, so there are different features of loss of function versus gain of function. It was strongly felt that autism or developmental delay or movement disorders without epilepsy and lack of response to sodium channel blockers all were strong predictors, or there was strong consensus that those were features of loss of function. Later age of onset did not actually reach consensus there. I think there are some patients with gain of function that can have later onset. And then recommendations in regards to counseling are included here. So these are things that caregivers also felt very strongly about, but there was a lot of consensus around these different points that are important to counsel families about, including the phenotypic spectrum, comorbidities, the likelihood of drug-resistant epilepsy, a seizure action plan or rescue plan, risk of SUDEP, and other items. Might be a bit hard to see here, but this goes over the phenotypes and the likely functional effect. So again, there was a reasonable consensus on the existence of these different phenotypes, ranging from severe developmental and epileptic encephalopathies down to the self-limited focal infantile onset epilepsy, and then neurodevelopmental disorders, either with or without epilepsy. Those were there was strong consensus that without seizures with neurodevelopmental disability, these are due to loss of function. And the gain of function, there was moderate consensus that gain of function is associated with the severe developmental and epileptic encephalopathy. There's also was strong consensus on the first symptom you can see here, whereas seizures are the first symptom for these two phenotypes, whereas developmental delay obviously is the first symptom in neurodevelopmental disability without epilepsy. The other thing I'll draw your attention to here are the seizure types. So for gain of function, for these three phenotypes on the left, these are more often associated with focal seizures, although you can have a vast array of different seizure types, including infantile spasms in the severe developmental and epileptic encephalopathy. And then the loss of function, this neurodevelopmental disorder with generalized epilepsy more commonly is associated with generalized tonic-clonic seizures and absence seizures. On to treatments, the optimal first-line treatments by phenotype. There was generally moderate consensus that sodium channel blockers are preferred for the selfie, the mild, the moderate, and severe DEEs. And patients with generalized epilepsy, the first-line treatments that are preferred are valproate, ethosuximide, or lamotrigine, things most commonly used for absence seizures. And then gain of function versus loss of function, again, is listed down there. So sodium channel blockers are favored, and there was strong consensus there that those should be first-line therapies for those with either presumed or known gain of function variants. In terms of medications to potentially avoid levetiracetam, there should be caution with using levetiracetam in patients with known gain of function, and caution in using sodium channel blockers when there's a loss of function. Also some ideas about when to add medications or how many medications one might choose. And those are listed here. I won't go into all those items. Again, continuing with treatments, there was some consensus in terms of other treatment options. So again, not just in going beyond sodium channel blockers, there are other therapies that can be useful, including things like um, dietary therapies, surgery, not including resection, but other types of surgery. There was consensus about having, a rescue medication plan in place, a seizure action plan, and those sort of things. Again, I won't go into all these. Okay. So the next paper talked about comorbidities. There was a fair amount of agreement in terms of comorbidities for patients with severe developmental and epileptic encephalopathy. And there are a number of comorbidities or risks, things like SUDEP. There was not consensus on SUDEP, but for many of these other comorbidities, there was a a fair amount of consensus on the presence of these different comorbidities for this more severe phenotype. And these things can either worsen, stay stable, or were mixed over time. In the other phenotypes, there was really not as much consensus. It's not as clear about the comorbidities that exist with the other phenotypes, and that was an area of where we think we need more active research. One thing you'll notice, I think, here is that the autism spectrum disorder behavioral problems are probably more common in this group um, and than you saw in the developmental and epileptic encephalopathy. Whereas also, I should say, is also were some of the more prominent features, I think, and felt to be more severe in these patients, whereas a lot of these other things were not felt to be as severe. So for selfie, even selfie is probably not free of other uh, comorbidities, so it's not a benign type of epilepsy. Some of these patients, at least this is the proportion of clinicians who felt that each comorbidity occurs in selfie. And again, it may not be entirely without other comorbidities or other problems, including things like hypotonia, motor speech delays, intellectual disabilities, autism, and other things. Getting closer to the end here. So resources provided to families, again, recognizing that this is a complex epilepsy that can have multiple different accompaniments. It's important to have multidisciplinary care, to have other resources that can be offered to families, including things like therapy, access to complex care, access to other specialists, and then inclusion of research and advocacy groups, particularly important to this audience, I think, since we have lots of adult neurologists here, adult epilepsy specialists, it's important to have a transition plan for these families, again, recognizing how complex they can be. And then in terms of prognosis, so this again is broken down according to phenotype. The patients with selfie, most of these patients do exhibit significant improvement. Many of these patients can be seizure-free, some on medications, some off medications. The severe DEE, a lot of those patients can actually deteriorate. And then the other phenotypes, it's kind of mixed. And down the bottom, you can also see that seizure freedom is rare or really never occurs for severe DEE. You can have some seizure freedom for patients with these other phenotypes. So at the end of this, we identified several different areas in which there was not consensus. So there are several research gaps here, including movement disorders that can present in SCN8A, sleep disturbances, autonomic dysfunction, GI comorbidities. cortical vision impairment, SUDEP risks, it's still an active area of research, pulmonary risks, and clearly need better characterization of the selfie phenotype and probably those milder DEE phenotypes as well. We really don't understand the comorbidities as well in those other phenotypes. There's some limitations here. Again, this is class 4 evidence. In regards, so have to take this with a grain of salt, obviously. Um, the phenotypic designations are also susceptible to confirmation bias, and I'll talk about that in a second here. Not all clinicians had experience with a full range of phenotypes. There was a limited number of caregiver respondents for each phenotype, and consensus statements may not necessarily reflect the most up-to-date findings. But I do think there were lots of strengths in this, and that we had multiple experts in both clinicians and caregivers and researchers from around the world to give a global perspective on this. We had a pretty thorough literature review and these 3 rounds of a modified Delphi process to gain consensus in something where there really is not a great degree of idea in how we diagnose, evaluate, and treat these patients. Last couple slides here before I open up the discussion. This is coming out in Epilepsy. This is some work we've done with Michael Hammer's group on the phenotypes in SCN8A. So this is using the natural history, the registry data that Michael Hammer and his group keep. We used both a supervised and an unsupervised learning approach, machine learning approach, to try to characterize phenotypes. And the unsupervised approach yielded a few different phenotypes, which is a bit of a departure from what currently is out there and what I've just presented. So it yielded 5 different phenotypes, 2 presumably loss of function, 1 with seizures, 1 without seizures, and then the presumed gain of function phenotypes were different according to their seizure onset and then relative to their onset of developmental delay. So what they found is that in the severe DEE or developmental and epileptic encephalopathy group, the seizure onset was early, so less than 4 months, and the developmental delay onset was also very early. For a group that we termed a developmental encephalopathy or DE, they had early onset of developmental delay, later onset of seizures. And then there was one we're terming the epileptic encephalopathy group that had earlier onset of seizures compared to the DE group and later age of onset of the developmental delay. And interestingly, if you look at the effects of seizure treatment on development, you can actually see more improvement in development if you can get better seizure control in the epileptic encephalopathy group, whereas it did not seem to make as much of an impact in this developmental encephalopathy group. So this might be a topic for a future journal club. I think it's an interesting concept. We've all kind of batched these DEEs or developmental and epileptic encephalopathies into one big group these days, but there may be some utility in thinking about developmental encephalopathy and an epileptic encephalopathy separately. So the last, that's for the future. The last slide here is just a summary of all those consensus guidelines of what came from these 2 papers. And it ranges from, for all the way from diagnosis to counseling to phenotypes and treatments. But you can see here again, we felt that if, and in terms of diagnosis, all people with unexplained epilepsy, regardless of age, and neurodevelopmental disorders of unknown cause without epilepsy should undergo some sort of genetic testing, whether it's a panel, whole exome, or whole genome sequencing. In terms of counseling, there should be the availability of a genetic counselor, consideration of parental testing, discussion that there's about prognosis, the phenotypic severity, comorbidities, seizure action plans, SUDEP, and access to resources. The discussion of the 5 different phenotypes. There's the early onset and the later onset. The later onset are neurodevelopmental disorders, either with or without epilepsy. The earlier onset range from selfie all the way to a severe developmental and epileptic encephalopathy, which carries many more comorbidities. The first line treatments for those are oxcarbazepine and carbamazepine, and the first line epilepsy treatments for the later onset phenotypes, the neurodevelopmental disorders with epilepsy would be valproate, ethosuximide, or lamotrigine.
I did. Yeah.
General management principles are also listed here. I think a lot of the things we're very familiar with for how we manage epilepsies. One thing that came from this is it may not be useful to continue adding anti-seizure medications for these patients. So think about taking medications away when you add a medication. And it's important to have access to a multidisciplinary care, to advocacy, to research opportunities, and be thoughtful about transition to adult neurology. And that's it.
Thank you so much for this presentation. Excellent presentation. And we have a few questions in the chat box. I'm going to start first by the first question by Dr. De Carvalho. So, sorry, I lost the chat box. So yeah, so would you think that the phenotypes or phenotype spectrum in SCN8A and Dravet are nearly identical? Or how do you or could you conceptualize that different subunits of the sodium channel, like 8A or 1A, would produce different entities?
So, I think the phenotype for Dravet is actually very striking. There's a very good idea about, how Dravet presents and the age at which Dravet presents. Really it's in the first year of life, not in the first couple of months. Often with hemiclonic seizures, they're frequently fever provoked. They have normal development of the onset. They only get developmental delay later on. And in many cases, it's very different than what we see in SCN8A. There is, interestingly, a gain of function phenotype. I have a patient I'm seeing tomorrow with this for SCN1A that presents with an early infantile epileptic encephalopathy that's also you treat with sodium channel blockers. And is very distinct from that Dravet phenotype. Again, that's also SCN8A, but that gain of function versus loss of function produces a vastly different phenotype. I'm looking at the chat here now.
Yes, there's more questions.
Yeah,
the same
more questions within that.
Same topic. Yeah.
You have any information on the distribution of sodium channel 1A, as you did allude to on subunit 8A? Yeah. So there are different, not only different locations, I think, for where these are expressed on the neuron, but also different locations in terms of where they're, what types of neurons they're expressed on. So Dravet, for instance, is with SCN1A, there is evidence to show that they're more expressed on inhibitory interneurons in the hippocampus, for instance, and also in the Purkinje cells in the cerebellum. So that explains some of the movement phenotype. Dennis Law is on here too. He might also have a bunch of comments on that question. Not to call you out here, Dennis.
No, I only have questions to you.
Oh, okay.
Well, I wait. I will ask later.
Okay, sure.
So we have another question by Dr. Three. Can genetics determine phenotype, including loss and gain of function, or is that clinically determined?
So there are some specific genotypes that are associated with a particular phenotype. So there are many. So like there's an 850 variant that it's a severe DEE phenotype, and those kids can often have things like infantile spasms. So there definitely is some genotype-phenotype correlation, and we know that certain genotypes produce a gain or loss of function. It can be a little complex because you're testing these things, not you're testing them in the lab, and it's hard to predict sometimes. You actually see some variants that have a mixed gain and loss of function. So there's different characteristics they can produce, and it's hard to know which one will win out. we do see that the phenotype. So like with if you have a patient who presents with later onset seizures, primarily an absence seizure phenotype, that's actually very highly associated with what's been found to be a loss of function. So we've used that, and I think clinical trials are now also using the phenotype as well to understand which patients they might want to include in clinical trials, because obviously you wouldn't want to include somebody in a clinical trial for a drug that is going to block this NAV 1.6 channel when they actually have a loss of function, because that could effectively make them worse.
Okay, and we have another question by Dr. Najjar. So any data on the interactability from loss of function or gain of function and need of surgical evaluation for RNS, DBS, or VNS?
That is a good question. I don't know if we have a great degree of data on neurostimulation. It was felt, based on these consensus guidelines, to be a potential option for patients with intractable epilepsy due to SCN8A. We find the most severe phenotype, that severe DEE, it really is usually a gain of function when you actually do the functional testing or see what's reported out in the literature. So more often than a gain of function probably is going to produce your most severe phenotype in terms of epilepsy.
And one more question by Dr. De Carvalho. So would you not have to separate LOF or loss of function versus gain of function individuals before committing an individual to a sodium channel blocker anti-seizure medication? And would you be blocking too much the sodium channels if there is a loss of function?
Yeah, so you could potentially make patients worse. We had some patients in our cohort that seem to do worse on sodium channel blockers. So that is a potential risk. But again, it can. I mean, I say loss of function and gain of function, like, it can be easy to determine clinically, but there are many patients in whom they're variant. It's not known what effect that is, and again, the effects can also be mixed. So we often do go by phenotype. If they have more focal seizures or a mixed epilepsy phenotype, those patients will often respond at least somewhat to sodium channel blockers, whereas those with more generalized onset or absence seizures, you probably want to avoid sodium channel blockers, which you would do anyway in a patient who presented with absence epilepsy.
And we have a question by Dr. Tirlikova. And do you have any personal
Yes.
experience with the effectiveness of cenobamate and gain of function?
I do, and it's been very. I have two patients who have used cenobamate and to very good effect. I think they have. I have one patient who has been seizure free for several months now on cenobamate, and one who had more than a 75% reduction in seizures with cenobamate. And there'll be a paper, I think, coming out about that pretty soon as well.
Okay, Dr. Boranici, would combining two sodium channel blockers potentiate the seizure benefit in these patients?
We do sometimes use combination sodium channel blockers. So we won't use oxcarbazepine and carbamazepine, for instance, but you can use if there are patients who are on oxcarbazepine and lamotrigine, or that in combination with lacosamide, cenobamate, even phenytoin.
Dr. Dennis, please go ahead if you have the question.
So hi, John. It was really great overview. I just wanted to ask, how do you approach actually this classification in clinically in real world in a, let's say, 7-month-old child which just shows up, has maybe some delay, unclear, right? If there are already some delays and you see a seizure, just I'm really curious because it's hard, right? So if they're older, it's a little bit more straightforward, but also not really straightforward. And how do you define also response to sodium channel blockers? But because it's also not so straightforward, I think, to measure response very, scientifically. Just sort of some thoughts would be interesting to hear.
Yeah, so it's a great point, and with the retrospectoscope, it's easy to know if a medication has worked or not. So you don't have the benefit of having to see what their response to medications has been when you're first seeing a patient. So it's a great point. The earlier onset seizures are more often a gain of function. So and especially if you're seeing focal onset seizures in those patients, or that as the primary phenotype, and that's what Elena Gardella and Katrina Hansen and others have also described. You are probably going to use a sodium channel blocker in those patients. So that really helps. I think you always have to go back to what's your epilepsy phenotype, what's your seizure type. We have decades of experience in treating patients according both to seizure type and epilepsy type, and we really rely on that in how we treat these patients.
Okay, it's basically the onset is then guiding mostly. So having a test positive for SNA plus onset is then basically the baseline for decision making.
Yeah, I think so. And then parents they also want to ask about prognosis. So I will commonly go to the literature and see if this variant has been reported before, and if so, what's the overall prognosis. And then you can look at things like inheritance patterns too. So we do see sometimes this can be inherited from a mildly affected parent, but almost universally in that selfie phenotype, unless the parent's mosaic, in which case that can be different, obviously. But that's something else can help us to sort of guide our discussions about prognosis.
Thank you.
Thank you.
I think one last question, and so will we have in the future to design different sodium channel blockers based on the subunits they are purported to work on?
Yeah, I mean that's going on right now. So we have a trial for this NAV 1.6 blocker, and there are some other. I know Dr. Is he still on here? But there's other trials going on now, not that are selective not for the channel itself, but for properties of the channel, like this persistent sodium current. There are some drugs being developed for that, and cenobamate is actually one of the drugs that acts on that persistent sodium current. Dr. Klein was here, I think. So
he's still here.
But those things are certainly in the works. Those things are certainly happening.
Spam, and it's not here in spam.
Sorry, there's a study being done by Praxis on the NAV 1.6. Yeah.
And we're doing the neurocrine study on the NAV 1.6 blocker. And the idea behind that is, if you target a specific sodium channel, like with anything, you're going to be your therapeutic window will be better. You'll have less side effects and more specificity.
Okay. I don't see any more questions in the chat box. Thank you so much for this excellent presentation and the talks also, the questions. And the CME code is in the chat box. I can post it again. So thank you all for joining.